today. Thank you for taking a moment to use the chat feature and introduce yourself. If you can share with us your name and organization, that would be very helpful. If you're new to this group, we'd love to welcome you. My name is Libby Sagara. I'm with Blue Path Health, and I facilitate the group supported by Anthem Blue Cross, CalViva, and HealthNet. We appreciate their support. So we'll do a quick run through of our agenda today and then get started into our content. We'll take a moment. It looks like we have people coming in the waiting room, so thanks for introducing yourselves once again. We're going to share a brief snapshot of the activity, the e-consult we've seen to date. And we're pleased to have today a discussion focused on what is hitting our clinics hard right now. We know there is a surge in COVID cases. We know that you're all dealing with the Delta variant, and we appreciate your time away from your clinic patients. So today we'll hear from Dr. Marwan Haddad, who will speak to e-consult in response to COVID cases. We will have Marianne Souza speak to ConfirmEd clinic satisfaction summaries, the summaries that your primary care providers are giving us. And we have my colleague, Robbie Franceschini, who will provide an e-consult policy update to us all. We want to take a little bit of time just to hear from you. We know this is a hard time for you all, just what tools, what communications or resources might be helpful to you all. And we also have our team from UCSF who will speak about the Child Psych Access Program, and then we'll wrap it up for today. So thank you again. I see some people coming in through the chat and introducing themselves. Thank you, Michelle Adette from Arista. Thanks so much for joining us today. And others, thank you for sharing your intros there. As we welcome people to introduce themselves, just a reminder in case you're new on today's call, we meet on a monthly basis. This coalition is open to you, who represent FQHC's rural health clinics. We have Central Valley Health Network. We have our independent practice associations and provider groups, along with our plan sponsors, working together to improve access to specialty care across the Central Valley. So this group is open and inclusive to all. Please do share this with your peers who'd like to join us. We're pleased to have offered a couple of CMEs through this effort, and it's been great to see such great response and involvement in terms of our CME sessions. So it's been great to have not only specific subject areas around e-consult best practices, but those topics that are most important to you, such as pain management. As we know, we've been hit hard in the Central Valley. We as a coalition work to address challenges with primary care reimbursement, look to work with our plans to get those clinic patients covered so we can have a program that is inclusive of all patients. And we want to be able to help you as clinics to support your billing challenges. We appreciate all of your leadership. So both clinics and plans are really putting a lot of time and effort into making this program what it is and expanding it. And as a result of this program, we've seen growth move toward the North State too. So we're seeing e-consult expand across Northern California counties also. As a result of our program, we'll share data. We are super appreciative of our e-consult vendors who are sharing our activity to be able to show the volume of e-consults that you're doing across the county, and want to talk about the impact we're seeing upon specialty care. So we'll be able to share a dashboard as a result of this program. And as I mentioned, we're sharing your best practices. It's really getting national attention. As we've talked about on our prior calls, it's been great to see other groups to look at this program and really become aware of the great work that you're doing, and really follow your lead in doing such great work to expand access to care. So with that, I just want to share a message. I know we share this on our calls frequently, but just so as you communicate this program to your peers across the Central Valley, we want you to have some language that we can use to make this an easier concept for people to grasp. So some people, when we share the idea of e-consult, try to grapple with what type of telehealth it is. So as we talk about asynchronous or peer-to-peer e-consults, we like to share that this can be used or considered as the first step to a specialty referral. And with the goal of our coalition to use e-consult for all non-urgent, routine, and non-procedural referral requests. So we know many of you are trying to do that in your clinics, and we appreciate that. There are a lot of questions around who has that patient relationship, and what's wonderful about eConsult is that relationship remains with you as clinics. So primary care providers have the decision-making power and when is an eConsult appropriate, and they have that relationship with the patient. We'll talk a little bit about that today. So we want to do a quick snapshot and just review what we've seen over the past month or so. So we're looking right now at a dashboard provided by ConfirmMed. You can see clinic volume by practice, and we saw a peak sort of in springtime, and we understand why eConsult utilization may be impacted in recent months, especially with the COVID surge. But what we've seen remain consistent over time, which is just so wonderful to see, is that the ability for primary care providers to address patients' concerns without the need for a face-to-face visit has remained consistent. So as you can see here, over 80% of eConsult requests are resolved without the need for that patient to be referred to a face-to-face visit. So we're just so pleased to see that resolution rate. It's amazing. And we also, it's also great to see which specialties are being done in great volume. You can see moving from left to right here, we see great traction in terms of GI, neurology, cardiology, ortho, pain. And it's wonderful to see that providers have been able to utilize eConsult in response to pain management with the recent closure of lags. And we know that that's been an issue for your providers. Any questions just on activity that we're seeing to date, or comments, observations of what we've seen so far? Also, if you're on mute, you're welcome to unmute yourself. You can also use chat to respond or to share any thoughts that you may have for us today. So this is the snapshot of clinics that are using ConfirmMed, and we also have a wonderful snapshot here of the Clinica Sierra Vista activity. Clinica Sierra Vista is on Rubicon MD, and it's great to see great traction here too. We hear from not just Clinica Sierra Vista, but across the state and country that dermatology eConsults are very effective. They're in high demand and also very hard to get in terms of a face-to-face visit. So we're seeing great use here for dermatology. And it's always wonderful to see such a high satisfaction rate. You can see here that through Rubicon MD being able to capture provider satisfaction at the completion of the eConsult, you can see great ratings in terms of the view of the educational value of the eConsult. And what's wonderful to see also is that the volume has remained high, and it's great to see Clinica Sierra Vista remaining active in eConsults. Just with a recent drop, perhaps we're seeing an impact because of COVID also. Any questions or comments? Great. Well, really the focus of today's call is in response to you all. We, meaning our plans, are obviously the eConsult platform vendors, and our team reach out to you as clinics to figure out how we might be helpful, what tools, resources, workflow support we might be able to provide to improve your eConsult experience. And what we've been hearing recently more than anything for those in Central Valley is that it's really tough to focus on anything aside from just COVID response right now. So with that, we decided we'd make this call today and discussion around how eConsult is being used to address that COVID-19 response. We know that you have a lot of reporting requirements with regard to Medi-Cal and DHCS, so you have a lot of pressures. So we want to be able to help think about how eConsult might be used in that response. So I'm going to hand it to Dr. Marwan Haddad, who's joining us from Community Health Center, Inc. in Connecticut. He's Medical Director of Center for Key Populations, in addition, a leader at Weizmann Institute and an expert in COVID response. So Dr. Haddad, if you wouldn't mind unmuting yourself and go ahead and please do share any background that I might have missed there.
Sure. No, thank you, Libby. Good afternoon or good morning, depending on the week. I think we're just afternoon at this point for everyone. It's good to be here. Thank you for asking me to sort of come on and just share these two examples for eConsult. So I just, in addition, I'm a family physician by training, and obviously work at a large federally qualified health center. You may be familiar with Community Health Center, Inc. So my role today really is just to present to you a couple of cases on how e-consults can sort of work, especially when it comes to COVID. And I think these two examples will give you a sense of the type of questions that we are getting now in the outpatient setting when it comes to COVID. So we can go to the first case. So this is a case, and we can go through it relatively quickly. I know that I think we have clinicians and non-clinicians who are on. The first question here is stuff that we are getting now, and we're getting a lot of calls into our health center around the booster dose, right? Everybody's hearing about the booster dosing and whether it's the third dose or whether the booster doses are going to be coming down the pike. And so this is something that you can get a fairly quick response on from there. So this was a patient who I believe was 40 years old, and the e-consult question really was about the fact that does this individual now who's asking requiring the third dose of the COVID vaccine. So his situation is that this particular individual had COVID in December of 2020. Luckily, it seemed to be mild, did not need any hospitalizations or treatment from that point, and then received the first dose of Pfizer in May. So 5 months after his infection, he ended up starting the first dose of Pfizer May 14th and got the second dose around July 2nd. No history of any immune system issues, so no real history of immunocompromise or being on any immunocompromising medications, whether it's the biologics, the immunomodulators, or whether it's chronic steroid use. Now the patient wants to make sure whether he's been hearing obviously about it and wants to know whether he needs another dose, or given that there's an extended duration between the first and the second dose. So I think the question was, I was a little bit delayed between, beyond 28 days between my first and second dose, and now that I'm hearing about the boosters, do I need a third shot or not? So, and so as Libby was saying, that, a lot of times these e-consults really are great in terms of helping with education as well, because you might send this once, and then once you get subsequent questions that sort of come in, you now have the answer and know how to sort of respond to your patients who may be coming in asking similar questions. So the specialist response was the following. So basically said, thanks for your interesting consultation on this 40-year-old who got infected with COVID, and then followed up with the series of messenger RNA sort of Pfizer vaccines in mid-May and early July, basically indicating that this individual is relatively young, doesn't really have any other comorbid conditions, especially no immunological issues. In other words, saying for the most part, right, the concern is, did this individual mount an adequate response to the vaccines to make sure that he's protected moving forward. So not only did this individual actually have the infection, natural infection, so probably mounted some immune response there, but we also know that the vaccinations end up mounting a more robust and consistent response across the board for all people, right? So we know that some people mount a natural response infection to COVID, but others may not mount as much of a response. But we know that the vaccine actually ends up mounting a more consistent and robust response across the board from person to person. So this person has really gotten quite a number of exposures to COVID as well as to the vaccines, which is great. So basically what this answers is that the immune schedule, right? We don't really, they didn't have much time to figure it out when we sort of started doing that, but definitely according to Britain, as well as in Canada now that we know with the AstraZeneca vaccine, that they extended it beyond what we knew from the trials, right? So all the trials were around 28 days apart, but definitely in Britain and in Canada, we knew that they actually went 90 days, just from a public health perspective, and went out on a limb without much data behind it. And we knew from real world data that was actually fairly adequate. So, so in response to it was beyond, the 28 days, first and second shot, is that adequate or not? We believe that it is probably fairly accurate. And so much so that the CDC has even said that going up to 6 weeks is okay, but even maybe it being beyond is not a problem. So this man received it within 6 weeks. So I think the vaccine sequence that he had was more or less accurate, as the consult sort of explains. And that regarding the booster shot, basically further adds, as part of the education, that at this point is not necessary to get the booster. So basically says, I would hold off on immunizing again until at least January 2022. So what we do know now is that there is contemplation, right, that most everybody could get a booster shot 8 months after their initial series. And so, given the fact that, we got it in May and July, that 8 months puts it around January, February of next year, if that plan sort of continues to proceed in terms of the need when the CDC and the FDA will looking at boosters. And that is all based on the fact that that we have some data showing that immunity wanes for many around the 8-month mark from some of the Pfizer data. So that's where all of this is brought together in this e-consult. And what I loved also about this particularly is that he also, whether it's he or she, I can't remember who the specialist is who answered this, but more or less sort of added on the whole issue around the WHO basically saying to developed countries, please don't proceed with boosters because we need the first set of shots for the rest of the world at this point. And so if we can concentrate on that. And so basically he or she adds this on, right? That we will have more official word from our health authorities and there'll be more vaccine produced, hopefully, so we don't have these ethical issues as raised by the WHO and poor countries such as in Africa who don't have access to vaccines at this point. So any questions about this?
This isn't specific, and I'm not a clinician, Dr. Haddad, so I'm just wondering, do you see, if you think of like the trends of types of questions that you're getting that are related to COVID, are there any, is this sort of the typical question that you're seeing? Are there, what are the sort of the nature of the questions that you see?
Sure. I mean, right now, I think that's a great question. Right now, because it's much more topical, obviously, whenever something gets announced in the media, we get a higher sort of uptick of questions around that, and the booster shot has been out there for a while. So a lot of our calls and a lot of the questions that are coming in are related to boosters, and when can they get them? Are they eligible for it? Should they need them? So on and so forth. But I have to say that, and this is sort of separate from the e-consult, we also still have a good percentage of our patients who have not gotten the first series, right? So in addition to the booster questions, we are trying to continue to talk to all of our patients about actually starting the series in and of itself to get vaccinated in the first place. So those are the vaccine questions that we're getting at.
Here's another one for you, Dr. Haddad. As you said this with in response to patients who may not have gotten a vaccine, or I don't know if you have reluctance, but do you have sort of a standard response? I'm sure you're getting very similar questions. Should I get this or should I not, and why? Do you have sort of a similar, like a template of a response of this is why you need to do this, or is there any way to help to make this more efficient for you?
Yeah, no, I think that's good. The issue is that we've done a lot of training across our organization for a lot of our providers across the board, medical, behavioral health, MAs, nurses, provided them with talking points, right, of sort of myths and sort of responses to some of the myths that are out there regarding this. And it's interesting. I think that helps in responding to some of the stuff, but I think it is a case-by-case basis.
Of course.
So what we're finding is that there is a gut reaction that may not be rational, that people are hesitant about wanting to get the vaccine. And so, you can present the data, you can say, well, it's, millions of people have gotten it. These are the side effects. We're not seeing long-term side effects. The other more serious side effects are extremely rare. It wasn't developed so fast. We've had a lot of data from the first SARS outbreak back in 2002, and we know a lot about coronaviruses, and messenger RNA technology has been around for a while. You can present all that, but at the end of the day, it still remains a gut response. And so what I do and what I tell people to do is just sit down with the person, explore in a non-judgmental way exactly what may be the hesitation around this, what are their concerns, and then try to address those concerns at those levels, and just sort of and definitely, although it seems to get harder and harder to remain calm and not judgmental,
Yes.
given what we're seeing. But I think, you got to find your inner peace, find, your non-judgmental sort of voice and approach to be able to really connect with patients, and people, actually, maybe your family members and others, and try to explore exactly their hesitancy and address those.
That's a helpful reminder. Thanks so much. I'll go on to your next case since this
Great.
is helpful too. Go ahead.
So this case really is at the other end, right? So this is an individual who did get infected with COVID, and now has residual symptoms. And so, the long hauler or the post-COVID syndrome that we're seeing a lot of, and large percentages, good percentage of patients who are getting infected with COVID are ending up with some of these residual symptoms. And we don't know a lot about this. And so we do get a lot of questions of people who've gotten infected who continue with these symptoms. Luckily, in Connecticut, we do have 2 clinics, pulmonology clinics, that do see post-COVID individuals, and they're sort of really gathering more and more information to sort of find out as more people are coming to see them. And so we have some experience, not us, but in general, in the world, we do have some experience about what's happening. But as you can sort of see from this response, there's not a lot of great treatments that we have for this, which is why prevention is more important than really treating the post-COVID concerns, or even treating COVID in and of itself. So as outpatients, right, we'll be seeing people either for prevention, so vaccines, hopefully for looking at people who are still either asymptomatic or mild, and monitoring them to ensure that they don't have to go to the hospital if they do get infected. And then the third case is those who have gotten infected and have sort of cleared for the most part, right, post, but are continuing to have these long-term symptoms. So this is a 53-year-old male, history of COVID infection in 2020, but continued to have fatigue and shortness of breath. And so they worked them up with pulmonary function tests and a CT scan of the lungs that did show some interstitial lung disease in what we call a restrictive pattern. So it's a little bit opposite from what you might see somebody who might be asthmatic, right? So that's more of what we call an obstructive pattern. So this is more of a restrictive pattern. And so they wanted to refer to pulmonology. And so what they found was, like we said, the abnormal diffusion through the pulmonary function tests, but the CAT scan itself looked like it was fairly normal. And so they wanted to say, somebody who's symptomatic, what do I do with this individual? So the response was, very appropriate and educational. Basically, it said the post-COVID state is known to have non-specific symptoms, such as fatigue, particularly associated with activity. And in many cases, the CT scans will actually highlight either you might see residual ground glass areas of infiltrate that might indicate that there's incomplete recovery of the lung. Obviously, this is not the case here. This CAT scan looked completely reassuring. However, the pulmonary function tests were abnormal. And interestingly, they said, again, some education part here, that the original SARS infection was associated with abnormal pulmonary function tests for almost 2 years before the lung returned to normal. So we're talking about the original SARS back in 2002 sort of saw that. So this may be a pattern that we might be seeing again with the current SARS, with the current COVID. So unfortunately, at this juncture, there's no clear medicinal therapy, so we don't have any pharmaceutical therapy that we can use, but we would recommend conservative management. Basically, we need to just continue to monitor and see how things unfold. Encourage patient to be as active as he physically is capable based upon the degree of the shortness of breath. Further, he should monitor his activities using a pulse ox. So something that we could help and say as part of your monitoring, if you don't get one, if you can afford one, get a pulse ox, or if you can provide them with a pulse oximetry, so sort of just basically see whether the individual starts to desaturate, meaning the oxygenation levels starts to drop. In general, it should be above 95% and higher up in people with normal lungs. Definitely, because we start to worry with people with COVID if it drops below 90%. And basically, he's saying that if this individual starts to drop again below 90, sort of less than 88% or so, then that needs further workup at that point. But hopefully, with the monitoring of the oxygenation through the of a pulse ox, that's one way to see whether they continue to improve if it's at a lower level at one point. What I liked about this is basically gave me, let's say, as a primary care physician, some straight to the point things that I can help with the patient. Basically, telling him, one, we need to monitor you, and we can offer you a pulse ox and see whether you can at least monitor that and make sure that it doesn't drop below 90%, give or take. But we also sort of said to continue to do any type of workup around the fatigue. So we shouldn't just simply assume fatigue is from COVID. So I guess reminding you more holistically, right? So sort of to maybe pursue other potential etiologies of why the fatigue is there. So basically make sure that they're not anemic or other things that may be going on, like another chronic infection. And lastly, basically, I like this suggestion to do pulmonary function tests every 6 months to really monitor objectively whether that the PFTs will continue to improve. And based on what he sort of said, maybe you might want to do it for the next year or two if they continue to be symptomatic. So any questions about that?
Hi, this is Delphine from San Francisco. I actually don't have a question about this specific, but I just had a broader question. I'm curious, these are great examples that provide a lot of educational value and are very generalizable, right? Can apply to many of your patients that you might see in your own patient panel. I'm curious if you guys have had or received questions about treatment, like outpatient monoclonal treatment or treatments that might actually the resources of which may vary by geography. And I'm curious how your e-consultants are recommending that or recommending who to go to figure out what's available in your area. Do you guys have best practices in that regard, or what do you recommend?
No, I think that those are great questions. So as Delphine sort of points out, right, like the 3 buckets of COVID would be prevention, right, with all the vaccines. Then if somebody gets infected, what do you do in terms of monitoring, and what treatments can we offer them as outpatient? And then obviously the post-COVID sort of recovery period. I might turn over to Libby because I don't see the e-consults coming in, but Libby might know whether we are getting sort of e-consults around that. Just keeping in mind, right, that monoclonal antibodies are indicated and if you have access to it, I think most places do have some access, although access can be a little bit can be a bit of a barrier, right, because it is an infusion, and even if there is a sub-Q aspect to monoclonal antibodies right now as well, but you still need to monitor them in a way. And so we at CHC we didn't set up an infusion center or monitoring, but we do have access to it in our communities. The difficulty is that we don't always hear from our patients immediately when they get COVID. We sometimes hear it, so they're either diagnosed elsewhere, and then we find out about it after the time frame of the 10, it has to be within 10 days of the monoclonal antibody treatment since they became symptomatic, right? And so, or if they became infected. And so definitely we should push for monoclonal antibodies because they are extremely helpful and do decrease by 70 to 80% hospitalization rates for those who are at high risk. Regarding actual treatments, I don't know whether anything has come in, but as far as I know, there is really no other indication of treatment as an outpatient in the US currently, right? So monoclonal antibodies to prevent worsening, and if they are worsening, sort of to get in. I know that there's a lot of talk about ivermectin, and there's talks about giving dexamethasone as an outpatient and some of that, but in general, I haven't seen any recommendations for that, although I think people are doing it on their own. But when you look at, the NIH and look at, IDSA and other bodies who are sort of, doing all the recommendations, there really isn't any outpatient recommendations. But Libby, I will turn it over to you to see whether you're seeing some of these e-consults come through more about treatment for those who do become infected.
I'm not Dr. Haddad. I don't look at the specifics of the e-consult since I'm not a clinician. So I mostly just focus on where we're seeing volume. And as you know, there isn't a sort of a COVID-19 specific e-consult request topic. But I did have one more question for you, but I do want to open it up to the group before I ask. Any final questions for Dr. Haddad? I'll let you pipe in via chat if you have them, but I do want to give you a compliment that came in. Dr. Haddad, Mary Renner from Central Valley Health Network said you do great work in terms of your speaking on vaccine hesitancy. So with that, I don't want to put you on the spot, but I am. Do you just have any general comments in terms of what advice you give? The Central Valley, having spoken to the Central Valley Health Network, it seems like you know a bit about the population. We do have a large percent Medi-Cal, and perhaps uninsured, perhaps undocumented. I'm wondering if you have any advice or messaging that you might deliver on vaccine hesitancy.
Thank you for that. I sort of already touched upon it a little bit at the beginning when we talked about the vaccines and the vaccine hesitancy. At this point, I think make sure that you have the facts, right? I think facts really can cut through a lot. And so know what myths are out there, but make sure that you have the right facts to be able to provide the information to the patients or to whoever is, hesitant about this. And then really approach it in a non-judgmental way, connecting with the patients in a way that sort of, so for instance, what I've started doing is if somebody says, you know what, I just can't trust it completely. And I sort of say, you know what, I had that same response initially. I looked into the data. This is what I sort of found. So I completely understand where you're coming from. And I had that too. Or you can sort of say, sometimes I say, somebody is like, listen, I'm recommending this to my mother. I'm recommending this, put it in a personal sort of way. So that way people know that this is what you're doing, but making sure that you know the right facts, connecting with them on a level to really find out exactly where this is coming from. And then really trying to move them along the way to sort of say, this is really good. Sometimes what I've been having is some of my patients say, all right. Next time I come in, I'll get it. No, that's fine. And so I make a mental note. The next time they come in, I say, all right, are you ready to get it now? Make sure also that people know how to get it and where to get it. So I know, I'm not sure exactly what your access is to vaccines, but ensure like if somebody wants it, to be able to give it to them immediately. So that way you don't miss that moment because they may just go back home, talk to somebody else who convinces them not to get it again, right? Sometimes it's helpful to speak to families, as a whole, because one person may be more on the edge, but maybe it's the husband or the wife that's more insistent not to get it. And so we really, I remember having one patient telling me, okay, you sort of convinced me, but now you have to convince my wife because I'm not going to be able to get it if my wife is not convinced. And so then, thinking about, because we do know that a word from your provider who's trusted goes a long way to convincing people. So making sure that it's trusted individuals who are talking to them, but we also know that the biggest influence, right, is your social network. If within your social network, people are getting vaccinated, then you're more likely going to get vaccinated. If within your social network, people are not getting vaccinated, you're less likely to get vaccinated. And so really working beyond the individual if you can. And I think a lot of us have been trying to do this work, but really working on more of community levels, finding people who can, speak, who are, well respected within the communities, who are representative of the communities, to be able to come out there and do this. I don't know if it's helpful or not. I don't have a silver bullet. I know you said that I do a lot of talk around this, but it's really comes down to knowing the facts, connecting with the patients, not being judgmental, and really trying to provide them with as much, decreasing the barriers to their getting them as much as we can.
That is so helpful. And you're so right. It's about community and relationships and families. So thank you for ending us on that note. And we'll send any other questions your way, but we really appreciate your time and walking us through these examples. Thanks again.
My pleasure. Bye, everyone.
Bye-bye. That was helpful to hear specifics from Dr. Haddad. And I'm going to take it to Marianne Souza now, who's going to talk a bit about the primary care satisfaction surveys that ConfirmED is conducting. So Marianne, I'll pass to you.
Thanks, Libby. Hi, everyone. I'm Marianne Souza. I'm the Senior National Sales Representative for ConfirmED. I live in Fresno, California. I've been here my whole life, and I've worked in healthcare for over 20 years. I just recently joined ConfirmED in May of this year, so I'm happy to be here. This first slide is showing our existing survey data for 2021. This was distributed at the beginning of the year for existing clients that were implemented before May of 2021. And we had 13 sites provide responses. And out of those responses, 72% of the providers responded that they were very satisfied or satisfied with the clinical guidance and educational value of our e-consults. Next slide. So our new policy for gauging our provider experience began in May of 2021. And the purpose is to really obtain feedback from our providers regarding their experience with using e-consults. We want to measure performance and identify any opportunities for improvements and just really provide optimum provider experience. For new clients, we will be surveying them 3 months after their go live date and then annually thereafter. And we typically like to send these surveys directly to the providers, but we can also send them to the practice site leadership who can then distribute them to the providers. And then the data is going to be collected and shared with the practice within 1 week. And along with the data, we want to provide the sites of information on strategies on how to improve the e-consult experience. So 2 questions will be included in the survey, rated on a scale of 1 to 5, 5 being most satisfied. The first being, please rate your overall satisfaction with ConfirmEd e-consults. And then please rate the overall educational value of ConfirmEd e-consult responses. There'll also be a comment section where providers can offer suggestions on how we can improve the e-consult process. Our providers are going to be given the opportunity to provide feedback on their experiences of utilizing e-consults in the referral process. And again, we're going to use this feedback to assess our processes and identify opportunities for improvement. So again, we're going to distribute these surveys to the leadership team or directly to the providers at a site. And then our healthcare account manager will follow up with leadership to remind providers to respond and provide direction for improvement and success. So all of that information will be presented to the site's executive team in a satisfaction report, and we will provide a presentation including the data and any suggestions on how we can improve their experience. Next slide. So the survey results will be emailed to all of our clients. The results will aid our sites and providers with performance, both positive and negative, and to increase receptiveness and utilization of e-consults. Our clients are also going to be able to compare their performance against other clients of ours. And really, we will work with our clients to identify and aid in any improvement improvement efforts. Our 3-month surveys have been distributed to United Healthcare, Valley Health Team, and Omni. And soon we'll be distributing to Altura, ARIA, Family Healthcare Network, and Camarena. And that's all I have, Libby. Thank you.
Thank you so much, Marianne. And those of you who are from FQs and clinics participating in this program, thank you so much for your participation. It'll be great to see the satisfaction results come back. Okay, we're going to have a brief policy update. Robbie Franceschini from Blue Path Health will share some updates relevant to e-consult. Go ahead, Robbie.
Sure, thanks, Libby, and hi, everyone. Just a couple updates. First on SB 365. Which would require e-consult reimbursement in Medi-Cal for primary care providers, including for FQHCs and RHCs. That bill is slated to be heard in the Assembly Appropriations Committee tomorrow, the 26th. So we'll make sure to keep tab of that. If it does get out of the Appropriations Committee, from there it would go to the Assembly floor to be voted on. And then if it gets out of the Assembly, would go on to the governor's desk for potential signature as well. Additionally, we wanted to provide an update just on AB 133, which is the Health Omnibus trailer bill that was signed by the governor in late July, which really just adds some policy to the budget that was passed earlier in June. It includes some details around a statewide e-consult service for primary care, pediatric, and family practice providers to manage behavioral health for their patients. This is part of a larger child and youth behavioral health initiative that the state is pursuing. We'll make sure to track that as well as any developments from the Department of Healthcare Services on this platform. Right now, they're still kind of in the planning phases, and we'll make sure to report out as we hear more. It also maintains all the current Medi-Cal flexibilities through the end of next year, including all the temporary flexibilities, specific to audio only and other forms of telehealth. And in the meantime, the department will be convening a stakeholder advisory group to determine, what telehealth policies should look like going forward in California, and what billing and protocols might need to be in place. And that stakeholder group should be announced at the end of August. And then additionally, I think through that process, there'll be an opportunity for folks to work through the advisory group members, including one of which will be the California Primary Care Association, to, advocate for eConsult, to potentially be expanded in terms of coverage and reimbursement within Medi-Cal. So I think there will be opportunity there for folks to get involved through the advisory group members. That's the latest and greatest in California in terms of a policy update. And I'll hand it back to Libby.
Thank you so much, Robbie. And we appreciate all of you and your vocal support for the work that's been done at the state level. And we may be reaching out to you again for your support if we see some movement happening with DHCS. So with that, I'm going to ask our UCSF guests to speak. I believe Dr. Reeder is on the phone. Michelle, are you there?
Hi there. Yes, thank you so much. And I think Dr. Steinbushel may also be here with us, but we are two child psychiatrists. We've talked to the eConsult Coalition before about our CAP program, but just kind of transitioning from what Robbie said in terms of this new, sort of focus on behavioral health and mental health for children in California. We wanted to encourage everyone to enroll in our UCSF CAP program. So we are a telephone consultation program that provides consultation between primary care providers and our child and adolescent psychiatrists. We're free of charge, or philanthropically funded, and have a variety of services in addition to the consultation, including webinars, educational events, and as well as a direct connect with our psychologists that we can offer as well. My email is here on the slide that Libby has shown, so please feel free to reach out to me. I'd be happy to talk and connect more on how we could work with your practices. And we really encourage you to complete our enrollment form that's on our website for a really simple enrollment process to get started for our consultations. Thank you, Libby.
Thank you, Dr. Reeder. And just to note, this link that is on the screen here is in your email. So if you are with a clinic and you'd like to complete the CAP enrollment form, you have it in an email from me that you received earlier today. Any questions for Michelle or for Dr. Steinbushel either? Okay, thank you so much. Thanks for attending our monthly calls. We really appreciate your time. Just so you all know, I think you're familiar with our site, our econsultworkgroup.com/Fresno site with the resources for the Central Valley eConsult Coalition. In addition, the econsultworkgroup.com site has publications that you see on a monthly basis coming through via our newsletter, playbook, which includes your program and your advancements across the Central Valley. And if you need any specific resources, you can always contact us if you'd like a specific tool or publication. And you can save the date for our virtual eConsult work group coming up on November 3rd. We were hoping we'd get to meet in person this year, but as you know, this environment's not helping with that. So we'll hopefully you can mark your calendars for that date, and we can see you on in our annual meeting. So we'll take a pause for a couple of quick announcements. We know not only is our state dealing with our COVID response, but we're being hit hard with wildfires and our health plans that are on today. We do have resources for you all. Karina, I know you wanted to make a brief announcement.
Yeah, thanks, Libby. Hello, everyone. This is Karina Mendoza with Anthem Blue Cross speaking. Thanks again for everyone joining our monthly roundtable call. I did want to share a couple of resources for our health centers. I know this doesn't typically apply to our Central Valley health care clinics, but we are offering access to live health online to all residents impacted by the wildfires. So if there's any of the residents up there impacted by the wildfires have access to Life Health Online, they're a telehealth provider. They offer on-demand medical and behavioral health appointments. So that is open to all residents. And then we've also relaxed our authorizations and prescription refills for all residents impacted there. And have deployed our emergency response iPad kiosks. So those are also out there, and the county offices are kind of managing where their location, where they're located at. So I know that they're moving them around a lot just because of the fires and where it's moving to. So those are out there, also available for members or any resident to access those telehealth apps available on the iPad kiosks. So just so everyone here is aware, if any, emergency were to happen here in the Central Valley, we do have dedicated iPad kiosks that we can put out there at different locations for that access to, telehealth applications. So I also wanted to mention that tomorrow I will be presenting at the annual telehealth summit hosted by California Telehealth Resource Center, along with my colleague Mohit. And we will be kind of just discussing, highlighting our telehealth programs. There's a remote care program, digital kiosk program, and the Central Valley eConsult Coalition. So we'll be highlighting those programs, talking about them, how to enroll. And we've also expanded our Central Valley eConsult Coalition into the North. We just had our kickoff meeting yesterday with our North clinics. So really excited about that. Everybody on this call has really shown great leadership and, moving that needle of adopting e-consults into the practice workflows. So it's really been showing great benefit for everyone. And yeah, so with that, we're expanding it. And those were just my two little updates that I wanted to provide for everyone on the call. Thanks again for joining, and I hope everyone has a nice day.
Thank you, Karina. A couple more announcements. And you brought up the North State expansion. We're so happy that HealthNet, California Health and Wellness, and CalViva have partnered with Anthem to move and grow this program. I know we had a couple of announcements related to that. And Mark, do you want to speak to California Health and Wellness CalViva response? Go ahead, Mark. Mark, you still may be on mute. Okay, well, we'll see if Mark comes off mute. And just, we'll take a pause for any additional announcements. Okay, with that, we'll make sure to get the resources that are available to you through email. And we can share anything that we hear that in response to COVID and additional announcements over the next month. We're going to try to meet on a regular basis. On a regular day, we've heard from you that it would be helpful to know in advance when these meetings will occur. We've tried to work around everyone's schedules as best we can. So we'll try to meet consistently on a monthly basis and also reach out to you for some check-ins so we can see how we can be helpful at this time. Any other announcements before we wrap up today? Okay, well, thank you again for your time and good luck. We're thinking of you all, and we'll talk to you next month.